Good evening and welcome everyone to this webinar provided by the European Patient Line by the European Spine Society on back pain solutions, which should help you to understand your treatment options if you are having back pain. This webinar will cover two talks by some really very expert speakers on conservative treatment options as well as surgical treatment options for back pain. Our learning objectives today is to help you understand what are the causes of back pain, to give you an overview of the non-surgical treatment options, and also discuss when surgery might become an option, and also show that surgery is definitely not a treatment option for every back pain. And we also want to help you by showing the long-term management options and prevention strategies to prevent recurrence of back pain. It is important to know that we're giving general information on this topic, but if you have a very specific question concerning your condition, you should best talk to your treating doctor or surgeon. So let me introduce shortly EUROSPINE. It's the Spine Society of Europe. It's a professional non-profit organization focusing on the advancement of spine research and treatment. And it aims to be your all-in-one destination for everything around spine. And to do so, EUROSPINE is running the Patient Line webpage, which gives information for patients with spine conditions explained in a clear, reliable, and trustworthy manner. It is available in several languages and can be easily found on the EUROSPINE webpage, eurospine.org. There you can just navigate on patients, and you will have the options to find different information about different locations of pain in the back. You can navigate through the different spinal conditions, and you can also find the link to our webinars. And all of that is available in several different languages. Let me introduce our speakers today. We have two experts with us today. The first speaker will be Lisa Roberts. She is a clinical professor for musculoskeletal health and consultant physiotherapist at the University of Southampton in UK. And our second speaker will be Jan-Philippe Charles. He's a very experienced spine surgeon, chair of the Department of Spine Surgery at the University of Strasbourg in France, and is our current vice president of EUROSPINE, so it's great to have him with us today. And let me also introduce me shortly. I'm an orthopedic spine surgeon at the Medical University of Graz. I'm head of the Division of Spine and Scoliosis here, and I'm, as a chair of the Patient Line Committee, I have the honor to moderate this webinar this evening. You have the option to submit questions throughout the webinar via the question and answers tool, and we'll try to discuss them at the end of the webinar. And this webinar will be recorded and will be made available online through our webpage. So if you want to review it, you can just go to eurospine.org and we'll find it there. So I will come back to the topic and would like to start with a short introduction on back pain. But I think it's very important before we talk about back pain that we have to shortly talk about the healthy spine. The spine is made up of several bones and discs and different anatomical structures. The discs between the bones act as shock absorbers. The whole spine is made up of 7 cervical vertebrae, 12 thoracic vertebrae, and the lumbar spine, which we are focusing on today, is made out of 5 vertebrae. Around the bone, we have strong muscles and ligaments who provide flexibility and movement to the spine. And within the spine, the spinal cord and nerves are running down to the legs. Low back pain is a very common problem, and if you are suffering low back pain, you're definitely not alone with that problem. It's located in the lumbar spine, which is also referred to as low back. And it's defined as a pain between the lowest rib and the buttock crease. So everything around your lower spine will be covered, or we try to cover in this webinar. Low back pain can occur at any age. And as I said, it's a very common problem. And around 80% of all people will have low back pain at least once in their lifetime. The World Health Organization published data on back pain showing that more than 600 million people were affected by low back pain globally in 2020. So it's really a common problem. Generally, we as doctors are differentiating between specific and non-specific back pain. The majority of acute back pain is a result of simple sprains and strains. And non-specific back pain is termed when it's not possible to identify a specific disease or structural problem causing the pain. So you have back pain also, or less, you have a otherwise healthy spine. And low back pain is non-specific in about 90% of the cases. If you have back pain and you consult your doctor, he will take a detailed history to rule out any underlying cause or signs of a serious illness. In that cases, diagnostic imaging such as CT scans, MRI scans, or X-rays are not required. On the other hand, we have specific low back pain, which is a pain that is caused by a certain disease or structural problem in the spine. And only if your doctor really suspects that there might be an underlying problem, he will then probably order additional testing to find out more and give a certain diagnosis. The treatment path for back pain covers various different options. We have conservative treatment options and some surgical options, but it has to be known that surgery is not an option in many cases actually, and it's definitely not the final treatment option for every back pain. You as a patient can contribute a lot to the treatment, and things like self-care and lifestyle modification are very important in the managing back pain, and especially also in managing the risk of recurrence of back pain. And with that, I already want to hand over to Lisa Roberts, who will give us more insight on the conservative treatment options for back pain.
Thank you very much. Thank you. Can you see my slides?
Yes, perfect.
Thank you. Well, good evening, everybody, and it's a pleasure to be here. And I would like to share with you, first of all, some guidelines about what the recommendations are for managing back pain. But I really would like to focus on what you can do to help your back pain in terms of what activities to try and some top tips to help at home. And then we'll briefly talk about 3 back pain treatments and some useful resources, as well as the patient line resources and some take-home messages. And as Peter's just said, you know, back pain is a global problem, and you can see the orange areas on the map show where back pain is the biggest cause of disability in those areas. It's around 1 in 13 people on the planet and has increased by 60% since 1990. Interestingly, it's grown most in Africa and Asia because the populations are getting larger there and people are living longer. And it occurs at any age, as Peter said, but it is particularly common in the 6th decade of life between 50 and 55. And 90% of people have this non-specific low back pain where there's no particular structural reason or disease that explains the pain. So last December in 2023, the World Health Organization published some guidelines, and these are the first guidelines on managing chronic low back pain. And by chronic, it just is a term that means the pain has lasted more than 3 months, and it's not due to any underlying disease or other conditions. So again, that 90% of back pain. And the guidelines say there are lots of things you can do to help yourself, to be physically active, to make sure that you do things you enjoy to help your mental well-being, to maintain your healthy body weight, to cut down or preferably stop smoking, to get a good night's sleep, and to engage in the things that make your life important and meaningful. So social work activities and things you can do, for example, to help when you're sitting. So in the guidelines, they recommended certain treatments, and these are spine education, such as what we're doing now, and advice, structured exercise programs. They also said that needling therapies, particularly acupuncture, can be helpful, manipulation and massage, mobility products, so that's things like if you walk better with a walking stick or a frame, that's helpful. Then there are some talking therapies. You might have heard of cognitive behavioral therapy or psychological interventions. Now you'll see on the list, the only drug there is the non-steroidal anti-inflammatories, and we'll talk about those. Recently, what's been added to the list is to put on your skin, so topical, cayenne pepper, and also a multi-component program. And I'm going to leave Philippe to talk about biopsychosocial care because I know he will be. Equally, the World Health Organization said there are a number of treatments that are not recommended, and that included traction and ultrasound and corsets, things like devil's claw or white willow, injecting local anesthetics in the spine. If you take drugs to help you lose weight quickly, TENS machines you might have come across before, that where you put a pad on the skin that has a little electric current. And you can see 5 drugs on there are not recommended. So that's opioids, antidepressants, anticonvulsants, muscle relaxants, and glucocorticoids. And this is, we're talking about here, these are not recommended for back pain. So what do we mean by being physically active? Well, it's little things that you can do that can make a huge difference. So for example, are you able to stand? Because standing is better than sitting. Are you able to walk, even if it's walking on the spot rather than just standing? And there are loads and loads of exercise physios and apps that can be helpful. And even something simple like a Fitbit that you put onto your wrist that can measure how many steps that you're taking. So that could be up to 10,000 steps a day, or ideally 30 minutes of exercise. And can you take the stairs instead of the lift? Do you enjoy swimming or gardening? And the idea is that we're going for 150 minutes of moderate exercise a week, and remembering to drink plenty of water as well. So any of those things that you can do will be really helpful. I thought I would share with you about the daily step count. And they've classified into if you take less than 5,000 steps a day, you're sedentary. You can see right through to more than 12,500 when you're highly active. And what's interesting is different countries have different amounts of step count on average. And you'll see if you come from Switzerland, you're doing really well, because people on average take over 9,500 steps a day, compared to the bottom of the list was the United States at just over 5,000. Now, people often ask me in clinic, well, what should I do to get more active? And the thing I would always say to you is, what would you like to do? Because if you enjoy an activity, preferably if you do it with other people, you are much more likely to keep going. And all of these things on the screen here are things that can be really helpful for helping you to become more active. Now, there are lots of different types of exercise for back pain. And the first one I'm going to talk about is mobilizing. So these are things to help you with flexibility, to improve your range of movement. Then there's things that help your strength and help you improve your power. There's exercises that work on your core and help you feel more centered. What's really important is aerobic exercise, which helps with fitness, balance for coordination, exercising in warm water that's known as hydrotherapy. And then when you've done all of these things, then breathing exercises can be helpful to enhance relaxation. Now, what did the guidelines show? Well, this slightly complicated diagram shows what the World Health Organization thought were helpful exercises compared to no intervention. And you can see that the more greeny blobs there are, the better the exercise. So what came in at the top was aerobic, but also the core strengthening, mixed exercise programs, Pilates, Qigong, Tai Chi, all of these things are very helpful. Interestingly, in the UK, we see that yoga is often recommended and does have some evidence, but that hasn't yet come in more in the world guidelines. So what are some of these things? Well, Tai Chi, if you sometimes see pictures of people in China, for example, in the parks in the morning, doing these wonderful circular, graceful movements, it was derived from watching animals and birds and trying to emulate that natural movement. And it includes movements and breathing techniques that strengthen the body, calm the mind, and help to balance that energy flow. And people usually perform it in standing. And if you were to watch people doing it, it looks a little bit like doing a slow dance. Yoga is a union between the mind, the body, and the spirit. And the aim is for the body to be in harmony and balance. And it originated in India, and it combines physical activity with a mental focus as well. And there are different types, and the evidence base is definitely emerging for it. I must admit, I'm a huge fan of it and think it's absolutely fantastic. And then there's Pilates, which was named after Joseph Pilates from Germany. And it's a whole lot of exercises that might be done on the floor or using apparatus like this apparatus here. And this works on the deep postural muscles. And the idea is that it helps with your spine alignment and to strengthen and rebalance the body. And it's been reported to have lots of postural, physical, and psychosocial benefits. And this was one of my undergraduate students here, Helen, who was a fan of Pilates, and we did some research a while back. And one of the participants said, I wanted to be in control of this pain. I didn't want to depend on taking these drugs all the time, and that's how I got into it. And then there's hydrotherapy. We've known about being in water for as long as mankind has been on the planet. But really, it was the Romans who first introduced spas. And hydrotherapy is exercising in warm water. And one of my undergraduate students, Jenny, did some research with this is our Monday evening hydro group. And they said, why did we come to hydro? Well, we've got better movement. We've got better function. Our quality of life is better. We feel better able to cope and we much prefer it to land exercise. And we've got less pain, less stiffness, less tension, less muscle spasm. We're taking less medication and we're needing less health appointments. And some of them have been coming for years, once a week, and it just helps keep them on track. And one of them said this great quote and said, I've never liked exercise, but while you're exercising in the pool, you can chat about everything and forget you're actually doing the exercise, which I thought made me smile. So alongside all this activity, there are also other things you can do to help yourself around the home. So thinking about your positioning, not going to bed when your back is uncomfortable or you've got leg pain. Have you tried applying ice or heat? And how can you make things around the home easier, especially if you have to lift or carry things? So as an example, if we think about how to sit, we want to make sure that our feet are flat on the floor and our hips and knees are at 90 degrees. And if you enjoy doing things like jigsaws or writing or art in some way, then these designer desks can be really helpful as well. Think about how you sit in the car for those of you who drive, just making sure that your seat is not too far away from the pedals can help you to sit more upright and obviously adjust your headrest. But what we want to try and avoid is sitting in low, soggy armchairs or slouching in bed like this lady is here. While she might be smiling now, if you've got back pain, that's not a good way to sit or lie down. And then there are some things you can do around the home. Ideally, our work surfaces are about 5 to 10 centimetres below your elbow. But obviously, we're all different shapes and sizes, and any of you who are very tall will find you probably are stooping when you're preparing food, for example, in the kitchen. So simple things like if you were to take some water, if you're preparing vegetables or washing up, and put it in the bowl, but put the bowl on the sink, you've immediately gained the height of the sink and don't need to lean forward as much. There's also sitting on perching stools. If you're carrying loads, particularly ones that might wriggle, this was my daughter many years ago, if you're carrying children or pets, then really make sure whatever you're carrying is really close to you, because that will put less strain and pull on your spine. If you find it difficult to get things out the boot of the car, then just putting a rug or a blanket in the bottom of the car, then you can just pull that towards you so that when you get your things out of the boot, you haven't got to stretch as far. And also, if you do pick a lot of things up from the ground, we talk about this golfer's lift, which is the technique you'll see a golfer doing when they get the ball out of the hole and they stick their leg out at the back. so they can lean forward and they find that more comfortable. So we talked about the things that you can do, and then there are some other conservative treatments that have been recommended by the World Health Organization. So the first one is what we call manual therapy. It's treatment with people's hands, and it can be mobilizations, which is moving the body within its normal range, or manipulation, soft tissue techniques like massage. And many people offer this, but the most common groups are physiotherapists, chiropractors, and osteopaths. And then there's acupuncture, which is thought to be the oldest system of medicine still in use today. And I would say it's particularly helpful for pain relief. It doesn't do anything to put right any changes in the tissues, but we use it quite a bit in our department to help with pain relief if it's the pain that's stopping people being more active. So sometimes we will do a little bit of acupuncture alongside helping people to get moving and get on with their lives. And there's been some very good biological evidence that I'm not going to go into today, and also some functional brain scans that show what actually happens when we put needles in, and that could be very helpful. Now, you may be thinking, what about medication? And this is the only slightly complicated slide I wanted to show you, where when we look at research, what happens is we do a lot of reviews and we look to see whether or not there is good evidence for particular types of drugs. And this was a review that was done in the British Medical Journal. And you can see the important bit is this blue, turquoisey blue line down the middle. And what we do is put each study alongside as a separate line on the graph. And what you're looking for is to see whether or not the effect that the study shows is on the right or the left-hand side. So if they do a study and find that the drug is better, for example here, then you would find that your little blob would sit over here. If, on the other hand, the placebo or sham treatment is better, you would find it would sit over here on the right-hand side. But what's important is all of these individual studies, the blob and the lines have crossed the centre, which means the drug is no better than the placebo. There is only one on there. And you may think, well, why is that? And to be honest, the reason we think that is the case is because people have very different sorts of back pain. And I know Philippe will be talking about that. And what we don't know yet is what drugs work best and for whom. And sometimes people might have back pain from a back strain or muscle that's been sore, or they may have nerve pain, which is going right down the leg to their foot. So the medication for those might be quite different. But the problem is a lot of research says back pain, leg pain, here are some drugs. And this is why we think medication doesn't show to be as effective as we would think. And sometimes medication is very helpful when you first have back pain, but when you are several months down the line, it can be that you end up taking medication for a long time and you're not getting the benefit of it. And sometimes it can make you feel quite rotten as well. Just before I finish, I just wanted to have a quick plug. If anybody's on the call from the UK, one of my PhD students, another Lisa, Osborne Jenkins, is doing a study where she wants to hear from people with persistent or recurring back pain about coming back in and out of health services. And she would love to have a discussion with you. She's collecting data just this month and next. So if you are able to help with that or would like to know more, please do email her, and I know you'll have these slides afterwards. I'm really sorry we've only got ethical approval for the UK, as I would love to include you all. So just to finish, I'd like to share with you some resources that I think you might find helpful. Clearly, the EUROSPINE Patient Line resources are terrific. There's also a little 3-minute clip from Professor Tamar Pincus, who talks about chronic pain, and she does it brilliantly using plasticine. And Tamar worked originally on the Patient Line resources, and it can be really helpful for you and your family to watch that. And it can sometimes explain why you perhaps don't feel as happy as you used to and why your back pain might be getting you down. There's also a 14-minute TED talk from Professor Lorimer Moseley from Australia, who's a very eminent pain scientist, and he got bitten by a snake. And he talks about how that impacts on fear. That is a very big part of back pain as well. I've also put there are two more resources. The Chartered Society of Physiotherapy and the charity Versus Arthritis have lots of leaflets and booklets as well that complement what we've got in Patient Line. And then finally, if you think I'd like to be more active, but I don't really know where to find out more, our National Health Service has 23 free instructor-led videos. And there's things like beginners, aerobics, strength, Pilates, and yoga. So again, click on the resource and you will be able to have a look at those classes and see what you fancy. So my take-home message is you are the best medicine for your back pain, and self-management is key. We want you to keep active, but also think about doing the things you enjoy. Think about your body weight, not smoking, sleeping well, and really making sure you're still doing the things that you like and that are important and fulfill your life. I love there's two quotes here. One is, we can't control the wind, but we can direct the sails. We can't control that we've got back pain, but we can do a lot about it to help ourselves. And what I would say is, today is the day to start. Don't put it off, because life is about not waiting for the storm to pass, but learning to dance in the rain. And I think that's one of my favourite quotes. So good luck, and look forward to some questions after Philip's spoken. Thank you.
Thanks, Lisa. That was really a very great talk, an interesting talk. Thanks for being with us today. As Lisa said, we have the option to discuss questions in the end. So please remember, you can just type them in via the question and answers tool of the Zoom app, and then we will try to discuss them later. And yeah, that was a great talk on the various conservative treatment options. And I think it's really important to highlight again that you as a patient really can contribute, and activity is a very important thing. But there are also cases where we as a doctor might have to become more active and do a surgery, but it's definitely not in all cases, as we already heard. But Jan-Philippe will give us some more information about the surgical treatment options and when we really have to think about that.
Yeah, thank you, Peter, and welcome everybody from my side also. We will now focus on the question if surgery can be an option. And also we will check if surgery is not an option. This is probably the case in most patients. Well, most of you do not require surgery, and Lisa has very nicely shown the multiple solutions that could be used in patients who have low back pain. But I'll take you through, I would say, the indications of surgery and maybe also tell you what the limits are. So the objectives of this talk will be to explain when surgery is not an option, which is very important. The alternatives have been very nicely explained already by Lisa, but we'll just give a few insights also from the surgeon's perspective. And then, of course, we'll determine when surgery can become an option, what type of surgery can be done, and what the expected outcomes should be. So Peter has, in the introduction, given you an overview of the spinal anatomy, but I think it is quite important to get a quick recap to know exactly what we're talking about, especially if we will focus on surgical treatments and techniques. So the spine is made up of different segments. There's a cervical segment, which is in red here, a thoracic segment in purple, a yellow segment, which is the lumbar spine, which is the one that we're interested in, and the sacrum, which is actually nested in the pelvis. So we'll focus on the lumbar area and the lumbosacral junction, which is between the lumbar spine and the sacrum. So most pathologies that we will see will be seated in this area. Well, the thing is that the anatomy and the interplay between the different anatomic actors and components is a relatively complex thing, because there are some bones, which are the vertebrae themselves, made up of a vertebral body, which is can be assimilated like a cube in the front. And then you have a whole system of different ligaments in the posterior part. And the thing which is in the spine is the spinal cord. So the spinal cord is only the thoracic spine. In the lumbar spine, you don't have a spinal cord. So you usually don't become paraplegic here, which is often a fear of patients who will get a surgery. But you will have nerve roots, which is the continuum of the spinal cord, which will then end up in the nerves at the leg. The other component which regulates movement between the different vertebrae are the ligaments and the discs. So Peter has already introduced that a disc is a kind of buffer which will act between the different vertebrae to enable movement. And Lisa has shown you very nicely that all exercises that can be done during daily life, but also during physical activities, sports, and obviously rehabilitation, if we're talking about low back pain. Well, these discs and the ability to move are very important for the patients. Now, as you can see on the right hand, there are some ligaments that regulate the movements. So why do we need ligaments? So if we wouldn't have any ligaments, then we would have an excessive mobility in the spine and a range of motion, which is the motion that needs to be controlled, is regulated by these different interplays of ligaments. But on the other hand, you will see later on that the ligaments can also be part of a pathologic process that will need some treatment afterwards. Another very important part of the anatomy around the spine, which is probably, in my experience, the most important, is the muscle or are the different muscles of the back. And as you can see from this graph, there are a lot of different very powerful muscles that need to be trained and that need to be trained during, I would say, daily practice and exercise. This is what Lisa has shown you, and that will also need rehabilitation. In most patients, from my experience, that come into clinics, they have a very sedentary lifestyle, which is something which is very common today. And their muscles that you can see here in the back are just undertrained. And this is probably key as a cause of low back pain. Now, low back pain is a symptom. Actually, low back pain is it can be an impairing condition. It can also be just a very temporary condition. If, for example, you've done too much sports, if you've worked in your garden, you may experience back pain, which may then resolve very quickly, which is something which is very common. And as you could see from the muscles, I mean, if you do too much exercise or too much physical activity, this might just result in pain. Now, when do we talk about back pain as a symptom, or when does it become chronic? Usually, we as doctors define chronic low back pain as a pain that lasts for more than 3 months, and then this is probably pain that we need to care about. So it can be an acute episode, it can be chronic, but chronic low back pain really makes up our patients that we will see and treat and that are usually care seeking. Now, the causes of low back pain can be, well, different factors. And one of the factors that doctors look at, but also that patients look at when they look up on the internet or when they come in already to our clinics with an MRI or with an X-ray or with a CT scan, well, they will look at what we call degenerative conditions of the lumbar spine. But degenerative only means that this is a condition which is just a course of time. And as you can see here on the right hand, you have the discs on an MRI scan. And as you can see in between the different squares, these discs don't have the same amount of gray or the same shade. Some of them have a lesser height and some of them are a bit darker than the others. But this only means well, that their water content or their elasticity is a bit less, but this is something that usually appears over time. It's a bit like wrinkles on your skin, and no one would worry if you have wrinkles on your skin if you're over 50, and no one would go to see a dermatologist because of wrinkles over 50 years. And if you take an MRI scan of all people over 50, probably this is just a normal image. And usually in clinics, I try just to reassure my patient that this is not an illness, this is not a disease, and this often doesn't need any treatment and certainly doesn't need any surgery. The other thing is that low back pain is something which is a symptom which usually has multiple factors. I mean, it can, of course, be degeneration, aging of the spine, and osteoarthritis, and the muscles which are dysfunctioning. But also it can be just a result of different factors that are a complex interplay that play together. And it can be a psychological factor, a social factor, an event that you faced in your life. And usually it's just an interplay between these different factors. And sometimes we just cannot find the precise cause, but we as doctors need to rule out the red flags, which can really be an underlying treatable disease. Now, because of all these different factors, usually when we have a patient in our clinics who comes for low back pain, and if it's non-specific low back pain, so if when we ruled out a severe condition, we need to account for, I would say, the biological aging, pain that can occur because of the nerves which are around their pain, because of the muscle which doesn't function that well, pain, maybe because there is an inflammatory disc, pain, maybe because there is osteoarthritis. But we also need to look at the whole social aspect, because some people will just have, for example, a problem at their work, in their family, in their relationship, and some people will just face a difficult issue at some point of their life, which can then exacerbate as a symptom, which can be seen as psychosomatic. So there's a link between what we feel, what we experience as pain, and what you might feel as an illness or a disease. But actually, we have to account for all these different factors, also beliefs that people have if you come from different countries, different backgrounds, if you have different cultures. The sensation of pain that you might experience might not be the same. This is what we need to account for. So this is the basement of what we call the so-called biopsychosocial model that we need to take into account when we treat patients with back pain. And usually our aim is to cut down a certain vicious circle which ends up in catastrophizing, which means that you might have pain, you move less. If you move less, you don't feel able to move more because you have pain, and because you don't move, you will increase your pain as well. And so you have just to interrupt this vicious circle. So what about surgery now? There were very interesting guidelines and studies who looked at the chances of operating on patients who have low back pain without having pain in their legs. Now, the chances of improving by surgery is very low. It's below 20%. So I think this applies to most patients and to most people that we see in our clinics. I work as a spine surgeon, so it is my job to operate on patients. But I would say that I might operate one patient out of 10 that I see in my clinics, which also means that there are at least 90 or 80 to 90% of patients that come into my clinics who don't need surgery. I think this is very important. What you see on this slide here are the muscles again, and you can see just an MRI scan of the muscles. And usually radiologists and also surgeons don't look at the muscles. And you can see on the middle image the dark part in the at the bottom of this MRI here. These are the normal muscles, and if you see on the right here, you can see the muscles here, and there are some light gray parts, and you can see that the muscle have transformed into fat. So this is what we call muscle atrophy, which means that you need to do some exercise and just something you like, as Lisa told you, just to increase this tendency and to reverse the tendency to decrease the content of fat here and to increase the muscle here. And patients tend to lean forward a bit, which is also something that you can see in normal life. As we get older, this is just the normal course of life. But if we have the tendency to lean forward a bit, the tension that we will have here in at the back part of the muscles will increase, and if your muscles are not very strong, this will just enhance the pain. So some very important tricks that we use here is that you can use a brace or a soft brace eventually if you're standing long or if you're walking, but having just an aid like walking sticks will just be a discharge of your muscles in the back pain, which will help you keeping on with physical activity and decreasing your back pain. Now, when do we need to operate? So this is just the smallest part. It applies to maybe 10 to 15% of my patients. Well, actually, a surgical indication and an indication to operate might be considered if leg pain is also present. So back pain plus leg pain. And what you can see on this right-hand image here are two vertebrae. You can see a hole in between these vertebrae. You can see that the nerve root comes out between the vertebrae, and sometimes there can be a compression of this nerve root, which will then lead to leg pain, rarely a paralysis. This can be a disc hernia, for example. This can also be a narrow spinal canal, and this is where the ligaments that we talked earlier about come into interplay. So there is one pain that we should not operate on, which is chronic nerve pain called a neuropathic pain, which cannot be operated. But what are the most common conditions? You can see here typical nerve root pain, which are the typical situations that we see in more than 80% of our patients who have a compression of their nerve roots. A sciatica or S1 pain is at the rear of the leg, and which goes down to the foot. If you have leg pain on the external side of your leg and goes to your big toe, this might be the L5 nerve root. And if you have leg pain more anteriorly, this might be L4. And it can be due to a disc hernia or a narrow spinal canal. So what happens if the spinal canal, where the nerve root passed through, is very narrow? Well, this may lead to walking difficulties. And what people usually experience is that their walking distance and also the walking time gets shorter and shorter. Usually they have to make pauses because their legs hurt, and then after a short pause, they can go on walking. Usually, we as doctors also have to check if there is no problem on the vascular side, because this can lead to similar symptoms. Yeah, now, as already said, the natural course of the disc is to lose water content. It is very elastic in children, adolescents, and young adults. And as time goes by, usually this water content and elasticity gets less, but this is something which is strictly normal. Well, the disc acts as a mechanical factor, as a buffer. We also know that it is not only lifting heavy weights or working hard, which is the problem, but it's just the biologic course and the nutrition of the disc that will lead to disc degeneration. We also know that some genetic factors might lead to earlier degeneration in some people than in others. And what we can see on X-rays, as you can see on the left, but also on MRI, is that there might be some changes on the image. But this doesn't mean that you have to get an operation only because you have a degeneration. Now, what's the consequence of this degeneration? It's like if you would sit on a ball, or if you would compress a ball. Usually, compressing a ball will lead to some bulging on the edges of the ball. And this is exactly what happens also with disc degeneration. You can see here from this image on the left that you have a normal canal and a normal space, which is in white here, in between the disc here in the front and the ligaments in the back. But if the disc degenerates and if there is some bulging of the disc here in the front, and here the red part is the ligament which bulges in the back, then you can see that the canal is much more narrow than on the left side here, and then this can hurt your nerve roots, and this might lead to leg pain and eventually to walking difficulties. Now, this is just an example of an MRI which shows you a normal canal here in the bottom on the right image. And where the red arrows are, you can see that there is not much space. There is not much of this white space, which is actually the space for the nerve roots. And if this is present, and if you have leg pain and if you have walking difficulties, then a surgeon might eventually consider an operation. Now, what type of operations do we do? One of very common operations is just the surgical decompression of the nerve roots, which means that the surgical intervention will aim to create more space for the nerve roots, which itself aims to cure leg pain and to make the patient able to walk again after the operation. So this should be the main goal. So as you can see here, the surgical indication or the purpose of surgery is not to cure back pain, but usually leg pain and the walking ability. Now, from my experience, I can say that quite often it also has a positive effect or indirect effect on back pain if you decompress the spinal canal. From this slide, you can see that minimal invasive techniques exist. There are different techniques that could be proposed by your surgeon, but this is probably something that we will aim for as patients who will get a minimal invasive technique will probably recover better and quicker because the access to the spine and to the spinal canal and the decompression of the nerve roots is just done through a small hole under a microscope. Some other surgeons might also use an endoscope, which is just an alternative. But in the end, I mean, the techniques are very similar and the results that you will get are very similar too. Now, sometimes we also need to get a fixation of the spine, and this is what we call a fusion, where we want to fuse two vertebrae together. And this is something that is not always necessary if we decompress the canal, but sometimes it is necessary. And as you can see from these X-rays here, there are two vertebrae here with these red markings that you see on the right-hand side, which are not aligned. And if you have this kind of translation, this might indicate that you have some degree of instability between your different vertebrae. Well, your doctor might call that a spondylolisthesis or a deformity. Some people also have a degenerative scoliosis, and this might also lead to a narrow hole which compresses the nerve root. So if you consider decompression here, and if there is already an instability, the surgeon might not only remove a part of the bone and the ligaments and leave the spine like this, but also stabilize the whole spine with a rod and screw system. Now, the screws that you can see here on this CT are inserted into the vertebrae. They are linked to each other with a rod, as you can see here. Usually a graft or what we also call a cage is inserted in between the vertebra to aim for fusion and definitive stabilization of the whole system while we have decompressed the nerve root. You can see here from this slide, this is how it looks in the operation room. We will aim for something which is not very invasive. This is an operation that you can perform through a keyhole, through very small incisions in many cases. You will then rely on a certain amount of technology, which imaging in the operation room, and what we call a navigation system, which is basically, as you can see on the right-hand side, an infrared camera that captures some pieces that we put on the patient to exactly check where we are without opening up the whole back and to keep really minimal invasive. So this necessitates some intraoperative image guidance, intraoperative CT, or what we call CBCT, to exactly plan and know where the screws should be located without having a direct view on the area that we operate on. So in summary, I would say that the surgical treatment of back pain is not adapted to most of patients that we see with back pain. They really only need surgery if leg pain is present. A surgical decompression of the nerve roots might only be considered if there is severe leg pain, if there is a walking inability, and a fusion might only be considered if there's a certain degree of instability. Most of you and most patients will just need more exercise, physical activity, and I think muscle strengthening and doing what you like and what you do best is probably key. So with that, I would thank you very much for your attention, and we will remain open to your questions.
Yeah, thanks again for this presentation. I think it was really very interesting to see the different treatment options. We have seen a very wide variety from conservative treatments to surgical treatments. But as said, in most cases, probably it's not the surgical treatment which is the best options for the patient, and it's really also about patients who should participate, and we really want to try to motivate you to get active. If you have any questions, you can submit them via the question answers tools. I've just collected also some very common questions from my patients in the clinical practice. And maybe just start off with you, Lisa. I'm often asked about braces and if it's not a good idea to immobilize the pain for a certain period. Why are braces actually not recommended for patients?
Thank you, Peter. That's a great question. We used to think they were helpful, but actually what happens when you use a brace or a corset, then what happens is your own muscles relax and they don't do what they should be doing. And the only time that it's really helpful to consider that is if you are a champion weightlifter, and you will see, for example, in the Olympics where weightlifters will put something around their spine because for a very short period of time, they are doing something very, very straining and stressful on their spine, but they will only do it while they're actually doing the lift. And the problem is people, if they are wearing a brace or a corset to go out gardening and things like that, what's happening is the corset is holding your spine rather than your own muscles. And what we saw from what Philip was showing in his slides, and also from what I was saying earlier, is you want your own muscles to be like a corset that are so super strong. And that's why I think things like Pilates and those core strengthening exercises are really, really helpful for that, because you get to a point where your muscles are much better than the corset. Mother Nature's given us our own corset, and it's really important that we make it nice and strong. Thank you.
Thanks. Philip, you have talked about this generation. You have shown that this degeneration is not an indication for surgery normally. But if as a patient, I had an MRI and you can see that the discs don't look that healthy anymore as it would look like maybe in a 30-year-old patient. Do I have to be afraid that I will have more back pain than another person, or is it really a risk factor for back pain? Every disc degeneration I can see.
Yeah, well, actually, that's a very good question. And I would say the problem is that if you get an MRI, and usually you don't get an MRI right away, as you said in the introduction, you will see many different things. If you perform an MRI, even in younger people, you might see a degeneration, which in most cases is completely asymptomatic. So I would say, well, it's actually your symptoms which will guide you also in the treatment. In the past, I mean, surgery was performed in patients who had low back pain and a degenerated disc, If I look back 15 or 20 years, there were some devices which were called lumbar disc prosthesis or replacement, which was performed. And what I can say today is that we've completely moved away from that. So this is something that surgeons don't do anymore. So why don't we do that anymore? Because I mean, there is no evidence that these patients really did better, although the disc had been replaced, and although we believed, well, 15 to 20 years back, that replacing a degenerated disc would lower back pain. So definitely, what we know today is that a degenerated disc with low back pain without having any leg pain is probably not a good indication for surgery. So from my experience, I can also tell you as a doctor and clinician that it is very difficult sometimes if this degeneration has been described on an MRI, and sometimes people just need some reassurance and are looking for a second advice to really give adequate guidance and to explain that this degeneration itself doesn't need a surgical treatment. Again, you might see it in many people. I think disc degenerations appear just as a normal part of, I would say, the course of time. I don't like aging really, but this is something that we might see in many people. Now, in some patients get disc degeneration, and with this degeneration, they get a disc hernia, which then might cause leg pain. Then it's a different condition. If you have a patient who has leg pain also, an infiltration could be done, for example. Well, if it's really severe reluctant leg pain, or if there's some weakness in the muscles because it's a very severe compression, then of course we should consider surgery.
So I think that's really important to remember that this degeneration you might see in MRI scan or changes we see on the X-ray are just often a normal process of time, aging, we like to call it. Lisa, you have talked about the lifestyle modifications, and it's how important it is to really integrate it into life. And you also mentioned smoking. Why is smoking so relevant for the back? Actually, we know it's not healthy, but
it's an interesting thing. I think one of the things is that often people who smoke tend to cough quite a lot. And we know that when you cough, that does increase the pressure in the lower part of the spine. But actually, the main reason is because it's been shown that people who smoke have a very poor blood supply around the area where we start to get all the disc degeneration and things. And, you know, smoking, it's extraordinary that if you smoke cigarettes, that actually that can make a difference to the blood supply to your spine, but it's been very well documented. So, you know, there are a lot of alternatives to help if you do smoke. To start with, see if you can cut down. There are the nicotine replacement patches, and certainly a lot of your doctors, surgeries will help you with that. You're not on your own with it. And if you can get to the stage where you've cut down and preferably stop altogether. We don't know yet about the effects of vaping because it's really too recent to show what effect that has on the spine. So maybe in the future we will see similar changes, but certainly at the moment the evidence is, please, if you can cut down on smoking, then it's a great thing for your spine health, but also for your general health. Thank you.
Thanks. I think everyone knows that smoking is not the best for your body, but I think you really have to know that it is also linked to back pain, and it's important for that also. Maybe to sum up, last question to Jan-Philipp. We have talked about structural changes and specific back pain where surgery might rather become an option. Disc herniations already happen in younger adults sometimes. If I have a disc herniation, I actually have a structural problem in the spine. Does that mean that I will have leg pain for my whole life, or what kind of patients expect with a disc herniation? How many of those have to be operated on?
Yeah, well, that's a very good question. Well, disc herniations, you have to know that in one patient out of two, the disc herniation will just naturally decrease. and that symptoms might completely resolve with a conservative treatment, and that you don't need to have a surgery in the early stages. Now, when should we consider an operation on a disc herniation? Well, obviously, if you have a paralysis on your leg, if you can't move your leg correctly, then the disc herniation might compress the nerve root in a very severe manner, and then you need to get an urgent operation. That's the first thing. And also some patients have very severe pain, which cannot be cured accurately in the early stages because of a major disc herniation, which needs an operation at an early stage. But in most of the patients, I would say you can wait and see for a couple of weeks, even a couple of months. And there is, I would say, a chance out of two that things would resolve with conservative treatment. So now, if things don't resolve, then you might consider surgery after 2, 3, 4 months eventually, if pain still, if you still got pain in your leg. But this is only, I would say, less than 50% of the patients and of the cases.
Thanks. I think that's also important to know that really our body has a capacity to heal, and problems can resolve, and we can, as a patients ourselves, support that process of healing. And again, I think it highlights how important it is to stay active and to try to avoid surgery whenever it is possible, and especially to know that surgery is not always the best option. Actually, if you have back pain, it's rather the lifestyle modifications and the activity we have to do. I'll just think we conclude this webinar now. Thanks again to Jan-Philipp and to Lisa for your great talks. They were very interesting. I would like to remind you about our patient line webpage, eurospine.org/patients, where you can find the recording of this webinar and a lot of information around the spine. And I wish you a nice remaining evening, and thank you all for being with us today. Thanks.